Having dealt with the nails and the different types of pathology associated with the nail plate and the nail bed and the periungual tissue, we can move on to the soft and hard neoplasia affecting the rest of the foot. For the most part, it's going to be the toes, the long arch, maybe a little bit of the dorsum. The first thing I want to point out is that the area that we're dealing with has a variety of different presentations. Infection, again, is going to be something we need to be careful about, that we don't mistake it for a type of malignancy. But having said that, I did point out that you can get, or I will point out that you can get infection turning to malignancy when it becomes chronic. Deal with foreign bodies. Again, we're going to return to granulation tissues and then look at other types of tissues as well as cysts. Macmillan Cancer Support deals with cancer, and I'd like to introduce a colleague of mine, Afni Shah-Hamilton, who has done some work. She's probably one of a few podiatrists out there who are dealing with cancers, and in this particular case, and we've written an article that deals with toxic changes associated with chemotherapy causing problems associated with the nail and the skin, and it's really well worth bearing that one in mind. So it's kind of a reverse of my own talk, where I'm looking specifically at neoplasia. This is looking at in the other direction, the effects of chemotherapy upon the skin and in particular the foot, something that not many people have got into. The dermatoscope is our tool that we can use to look at the skin. Unfortunately, it is a little bit of an expensive piece of equipment. It's not going to be able to be purchased by everyone's pocket. It ranges from £50 to well over £1,000, depending upon the type of properties that you want from this particular instrument. The value of a dermatoscope is that it looks at both levels of skin, the dermis and the epidermis, and also looks at blood vessels, and it can magnify the area quite considerably as well as measure it. It can also be hooked up to take photographs, so you've got a good record. So dermatoscope is certainly something that's used particularly in melanoma. The infection that I mentioned earlier is something we need to be aware of, and this is what appears to be an infection, but in fact a biopsy showed there was nothing present in the tissue. An x-ray was taken. Nothing showed up as far as osteomyelitis was concerned, which would be one of the suspicions. You're probably thinking, well, this looks like gout as well, and that was tested for gout by blood test, and we opened it up, or should I say I opened the toe up to find no changes which typify gout. The area was cleaned out and bone was removed and sent off to histology, again showed nothing significant, and packed with antibiotic beads in order to try and clear up anything that might have been migrating into the tissues. This took some time to settle down, and it's one of those idiopathic conditions which could very well turn out to be a tumour of some type, but it wasn't. The other area that one needs to be mindful of is the wounds that open up, ulcers, erosions, which have these overhanging edges. This is just callus which is formed as part of the healing. The area of darkness there is obviously devitalized tissue and can be removed by debridement. This particular toe, or both toes, were long, and in the end these were shortened by an arthroplasty which cleared the lesion up. But obviously local care would help, but long term it's a good idea to try to ameliorate the problem long term. Diabetes is something obviously one would consider to start with before treating it, as well as if there was any neuropathy present, which there in fact wasn't. Now we come back to pyogenic granuloma. We mentioned this under the subungual pyogenic granuloma earlier. Pyogenic granuloma tend to arise quite rapidly within 6 weeks following trauma. They have a nice capsule, and you can see this area around here is capsulate and slightly macerated. The other thing is it bleeds. It can be quite uncomfortable and even painful, but it's general inconvenience that affects most people. This is curettage, so we can curette it out, excise it, cauterize it, or freeze it. So all of these things can be carried out. Of course, the big lesion that we're all concerned about is the melanoma, and this is one affecting the heel. This looks particularly gruesome in that you can see the centre is actually not healing well, although there is a sort of an area that looks as though it's well circumscribed here. This is actually malignant, and I wanted to show you this because it's very similar to one that I was presented with some years ago. A GP sent me a patient with a much larger lesion than this. It was certainly over an inch, affecting the plantar metatarsal, first metatarsal head. The patient was diagnosed as having a wart and was treated as such by the GP. I excised it radically, and as a result it was sent off, and it turned out to be an acrolentiginous melanoma, so it's pretty nasty. The problem with these is that they can metastasize, and we mentioned metastasis in the previous lecture, and it's important that a PET scan, that's a positron emission tomography, is carried out to check any organs being affected. The patient was well in their 70s and died 5 years after the surgery that we identified this with. The way that we need to approach melanomas, if I get you to recap the ABCDEs, the asymmetry that we see around these lesions, particularly if there's change within the main body, which we can actually see in this picture here. The border itself becomes rather uneven. The colour does change, so there's colour distribution changes. It can go from black to brown to red, and it can also bleed. The diameter also increases, and it evolves, including bleeding, changing shape, as well as being infected, could become infected, or it can certainly be uncomfortable to some patients. If we look at this particular melanoma, we can see there's something clearly wrong here. The area around the lesion here is breaking away, it's asymmetrical. There is a keratotic kind of surface to it, uneven surface. This whole centre here shows another area of change. It's evolving. There's probably some bleeding here, although it doesn't actually show it as a result. This type of lesion is naturally extremely suspicious, and one would need to send it off pretty urgently because there is a chance that this might have metastasized. The differential on this particular condition includes a warty type of appearance. This is a sebaceous keratosis, and this shows again breaking up of the keratin, so it's made up of acanthosis, which is uneven squamous cell distribution. And then the other appearance of the same lesion is this sort of waxy appearance. I actually have one of these on my shoulder, and over the years I've experienced it breaking down. It changes colour, in fact, particularly when it starts to break up, as in these little areas here. And you can actually flake these off. Doesn't actually bleed. It's well circumscribed. These edges, you can see, are very well defined, so there's no concern here. I haven't seen these on the foot as such, but it's just a useful comparison. If we look at this one, this is a blue nevus, and it can arise in patients' extremities. It's quite common in females, twice as common in females actually as men, and the histology shows spindle-shaped cells which are like fibroblasts which develop. So it's a kind of a nevus, and I haven't said too much about nevi, which are presented on feet as well as other parts of the body, including the face, where there are red areas sometimes, and if you compress the blood vessels, they remain dilated, so they don't actually change their shape, and as in a capillary refilling, for example. And the other area, the other condition I'd like to say is this is actually a halo nevus. So you've got this halo effect around the centre. And these occur sometimes when there's damage to the melanin, but in the case of the blue cyst, the sebaceous keratosis, and the halo melanoma, you can actually be reassured that these are harmless. Having said that, they always give rise for concern, and so it's useful to have a colour atlas with you, dermatology atlas, which can assist differentiate. But I think if you distinguish the central picture here, with the other pictures, you can see the difference between the different presentations. Something which is a little bit more common and certainly found in feet is the mucoid cyst found over the interphalangeal joints. Now, it can be associated with the joint lining here, and if that's the case, it actually forms this sac as a result. It's kind of like a synovial sac. It's filled with clear, slightly gelatinous material. You can aspirate it in some cases, but when it's associated with the joint lining, they do tend to recur. They can become quite large, and so they sort of kind of pop up and can take over the whole of the toe. And if that's the case, obviously they become extremely inconvenient for the patient. Normally, I would excise these myself, remove the interphalangeal joint to get rid of all the tissue here so it doesn't recur. And that does really well, and that can be done under a local anaesthetic as a day patient. The ganglion. Well, we all know and heard about the ganglia. This is one that's affecting the ankle and very common because it's over the sinus tarsi and the subtalar joint complex. These come off synovial tendons as well as the joints themselves, and they can be extremely tenacious and difficult to manage. Aspiration is possible. You do have to use a very large syringe, something like a 50ml syringe, to get the pressure up. Otherwise, you are not going to be able to aspirate the fluid off. The fluid should come out looking slightly yellowish. It's very thick, glutinous. But if there's a lining, and you can see the lining here, this has actually been preserved, this area here, and it's very shiny. Unfortunately, it's in black and white, but it was a reasonably good slide to show how thin, gossamer thin, this lining is, and it's very easy to puncture when you're doing surgery. The other areas, of course, the hallux valgus and the bunion, very common over the exostosis. That's the normal bone which expands as a result of irritation. Taylor's bunion, very similarly on the opposite side. And then we've got the dorsal tarsus. These are all very, very common areas to find the ganglion. Excision is certainly one way of managing it. Aspiration, fine, but short term in many cases. But they can make the patients a lot more comfortable, and that's useful. The midfoot bump, which is associated with osteophytes, osteophytic lipping, as shown in the red circle on the right-hand slide, can cause irritation of the soft tissues. The soft tissues are irritated. The lining of a tendon or the joint can actually then leak, form a new lining, and this forms the ganglion. So this is quite a common area where we find osteophytes or irritation as well. The bursa is another similar kind of cyst which forms in the foot, and this one's quite an elaborate one. This patient presented to me, couldn't put her foot in the shoe very comfortably, and you can see the enlargement here. One might find this in rheumatoid arthritis, particularly it affects this area of the foot in particular, the MTP joints. The lining becomes thick, inflamed with the disease, with giant cells. This is a typical bursa that's been removed, as in the foot here. You can see it's very fibrotic, thick. This is the yellow bit's the fat, of course. It's really a sac, and what comes out of it can be a dirty colour, brown, inflammatory muck, basically speaking. Now, as far as taking these out, which is obviously the objective and making sure it's sent off to histology to check for any abnormalities. My interest was really looking at the histology itself. These are not malignant at all. But the problem is that they are invasive in the sense that they cause pressure necrosis, and so the fat pad starts to disappear, and this means that the patient's walking on bone and it's very uncomfortable. So they do need support from soft orthoses, which will help them enormously, but they do need to be warned about it. This dermatofibrosarcoma is an example of one that I had. This is not the one that I had a picture of, but it shows you that some of these expansile lesions can be quite notable apart from affecting the footwear. The case history I can recall was a 33-year-old female who in fact was a Jehovah's Witness, and this caused us a delay in taking her to surgery. An MRI was carried out, which was actually not as helpful as we had hoped. The lesion expanded from the metatarsals through to the heel, so it took up most of the long arch. So she was in effect walking on a spongy sack. The dermatofibrosarcoma, we'll notice that the word sarcoma is a malignancy, and it's associated with connective tissue. So it's the more common form as opposed to a carcinoma. These are less migratory, but they still expand, causing damage. The patient, in fact, was sent to the Birmingham Oncology Unit, where I used to refer all my suspicious lesions to, where they needed further surgery. She eventually ended up with plastic surgery, but because she fell pregnant, the treatment had to be offset. In her case, after plastic surgery, they saved the foot, which was excellent. This is what we wanted to do. And there was no further concerns. It hadn't migrated anywhere. But dermatofibrosarcoma is one thing that you may come across because it's pretty alarming. Going back to sort of more normal tissue, this is a type 2 callus, if you're familiar with my classification system. Type 2 callus is a button-shaped callus, so it's very, very circumscribed, symmetrical. Deep inside this epidermoid cyst is formed by anything that penetrates the skin. It's usually quite small, glass, even pencil shavings, wood, bit of wood. Even a nail could go in there from a loose nail cutting. Dog's hairs. The picture on the right-hand side shows you kind of an illustration. This is a pilonidal cyst, which usually affects the spine and the hair around the back. But it does show you pretty much the same sort of thing, how the hair gets into the wound, it gets walled off. There might be a sinus tract. In this case, there isn't anything there. You might think when you see this patient, you'll just debride some callus down. It may be painful. It may not be as painful as you might think. But when we carry out an ultrasound, we can find a hypoechoic change here. This can be measured. So you have an approximation of the kind of size that exists. I may have mentioned earlier that the problem with the intermetatarsal space is that you can get lesions that migrate into these spaces, press on muscles, blood vessels, nerves, and so forth. And so it is a good idea to see if things are located, as this is, nice and isolated, so it's easily accessible. This is a metatarsal head here, and this is the edge of another metatarsal here. This is an upside down picture. This is fat, and this is water fluid here. Another lesion which I came across reasonably frequently was the plantar fibromatosis. This is a fibrous material. It's very difficult to say why it occurs at times. Certainly there could be association with irritation of the plantar fascia, and it's a aponeurosis. It's also known as Lederhosen disease. The disease obviously is a bit of a misfit, but it is benign. But it forms these areas here, the lumps. You can see a bit of callus there, but it can also migrate and cause lumps here and lumps here. And so this nodule appearance can be very, very difficult to cope with in footwear. Slight word of warning, if you're going to make an orthosis for someone with plantar fibromatosis, do make sure you have a cutout, because there's nothing worse than the plate of an arch support irritating the area. That's really a little bit unpleasant for the patient, and perhaps could get you into more trouble. Some people like to biopsy it. I'm not terribly keen on it because it's very easy to set up further fibrosis. And people who come to operate on these lesions, if they don't remove an adequate amount of tissue, I'm afraid it recurs, and it recurs with a vengeance. The kind of surgery you need to do is to do this. You have to cut all this out in one go, not mess around, because if you don't do that, the thing will recur. Do people need their plantar ponerosis? Well, it's ideal, of course. It's there for a reason. It's a mechanical structure associated with the toes. It helps efficiency with shock absorption, and we know all that. But can patients live without it? Yes, they certainly can, and it's probably preferable to have it excised rather than leave it there if it's a problem. But in a lot of cases, nothing needs to be done. This is a giant cell tumour of the tendon, and you see an MRI T1 picture here that shows good anatomy. You see the MTP joints. The whole of this area here is cloudy, dark, and this is the lesion here. The giant cell tumour is actually benign in this case, but it's very expansile, and you may find lesions such as the aneurysmal bone cyst occurring in the metaphysis of bones, so that has to be a differential diagnosis. The area, normally we excise the tissue here, take quite a large bite out here, double ellipse, remove all the tissue, and then suture it, and any excess skin is trimmed away, being careful that obviously the blood supply runs down here, and as long as you don't damage that, everything's fine, and the toe can look reasonably normal afterwards. But again, these particular lesions are relatively unusual. I'd like to move on to this one, though. This is pigmented velonodular synovitis. This particular picture is pretty gross in the sense that it's large and expansile again. Obviously, it's stretched over to the first MTP joint and all over to the fourth. So it's got potential to damage a lot of tissue in its wake. Excision again is important. This would be excised similarly, quite a long incision for this one, taking quite a lot out, and again any excess tissue would be trimmed, because once you've actually cleared the tissue away, this hard tissue, you're going to have a lot of redundancy there. Now it's interesting, this particular condition is associated with the colony stimulating factor receptor, that's the SF1R, and it's a question of turning this receptor off using medication. Pexidartinib is the drug of choice which can actually settle this down. So it's approach using a sort of a drug as well as surgery to deal with this. But it's non-malignant, but it just looks kind of nasty. And we come finally to another lesion, but this one, it looks like an inflammatory lesion. It looks vesicular in many ways. It could be pustular psoriasis. It could in fact be a dermatomycosis, so in other words, a skin infection, athlete's type foot. But it's not. This is Kaposi sarcoma, and it's associated with the human herpes virus 8. We know it well from the AIDS, the autoimmune deficiency syndrome, which became rampant around 1980s. It's typical in homosexual men, and then you will find it in Africa. It's quite endemic in Central Africa. Found in children as well. Unfortunately, it's passed on, and the other problem is that you can get immunosuppression with transplant surgeries. Anything like that can actually pick up this particular lesion. A small percentage, maybe 5%, die, but today we can use the highly active retroviral therapy, or HART, which can do much to suppress the condition. If you do take history from the patient, check as much as you can to see if they've travelled, if they've had bites, because arthropod bites can also transmit this particular virus, so it's kind of nasty. So in conclusion, and I said in a previous lecture on nails, the foot health practitioner and the podiatrist have slightly different knowledge base in the fact that they've been trained with a certain amount of clinical exposure. The FHP has a fairly limited clinical exposure and obviously pick up a lot of their knowledge once they're in practice, whereas the podiatrist is at a better advantage because they may have had placements in the National Health Service and generally a wider exposure to different patients, as well as the various specialties, including dermatology, which features very highly in some of these conditions. We need to couch our findings always in a sensitive manner. It may well be that the patient brings up the fact that they think they've got a cancer, and as such, then we, will have to go along with it up to a point. But I think the point I would like to make is that if we are talking about any lesion, simply say, I don't know whether this would be malignant. This is outside my area of expertise. I'd like to have a second opinion. But please remember, and you're talking to the patient, that the type of cancers in the foot are very rare indeed, even more so with bone. The chances of it being a malignancy is unlikely, less than 1%, but it's really useful to actually get a further diagnosis to see if we can treat this. So I think you've just got to be fairly sensible. You're going to be writing some kind of referral letter, and therefore you've got to be careful again what you write there. So the referral will depend, it's a bit of a postcode lottery, it'll depend upon you, your networking, whether you know people in the medical profession who can assist. The GP may be someone that you want to refer to, but of course there's always that delay. But if you've got photographs and you can send a letter in or something like that, that does in fact help the patient get faster management. The dermatologist is probably one of the first line people. If you can refer directly to dermatology, that's great, but just check locally. Rheumatologists are good physicians to use. They have a very vast knowledge of this sort of problem. Orthopedics, well, that's great up to a point, but they have a great delay, and they're probably not my first line choice necessarily, unless I happen to know it's a bone tumour. Then I'm sending it off anyway to an oncology service where they've got specialist oncology, orthopedic surgeons and plastic surgeons, as well as oncologists who can carry out the management from the chemotherapy point of view or radiotherapy. The importance, I think, of having information at your fingertips as well, references, is really helpful. And I think all practices should probably carry a colour atlas in dermatology. This particular book by Rachel Morris Jones is recommended by the Institute of Podiatrists, who use it in their course. And so I certainly would recommend that. And I mean, it's not you have to have this book. You can have any book, to be honest, but this is one that is recommended. They are fairly pricey because they're in colour, and colour costs a lot of money to print. So I would recommend a colour version, not a black and white one. So once you've got the dermatology book, that's great. But the other thing that you might want to do is to go on a dermatology course, learn how to use a dermatoscope perhaps. This is something if you want to expand your range of knowledge and confidence. The DermNet New Zealand website is fantastic, and there is a professional form that you can sign up to. It's all free, and they have a great range of pictures on it with lots of information about the different skin conditions. So that's really well worth going to. And lastly, my own site, Consulting Foot Pain. I write articles regularly. I've got a number of articles on various cysts, swellings, hard bone lumps in toes, biopsying, things like that. So you can find that on my website, Consulting Foot Pain. And how to access it, it's quite simple. If you go to my author site, you will actually see here, David Tollafield, author.com. Click on it. This is the face page. And then if you go to the area here, where it says more, it'll then bring down consulting foot pain there, and you'll find the articles. You can skim through the articles as you want. So I hope you have enjoyed this presentation, and it encourages you to have more confidence when you're in clinic and looking at a variety of lesions. I can't have covered all the ones that are possible. Ever more, these things tend to evolve, and it's really your clinical practice experience and exposure to patients on a daily basis that will give you the confidence. So I wish you well, and make sure you get yourself a good reference book.